What is your most unusual or crazy story diagnosis you've come across?
Well, there was one case. This one is very interesting because bladder full of urine, but she cannot urinate, and she starts to have some psychiatric behavior, psychotic behavior.
At that age, a bone marrow transplant the risk of something like that is pretty high too, right?
Yes, but at the same time, they are the best candidates. They could potentially cure the disease.
Is there something that maybe we didn't talk about that maybe you wanted to mention while we're talking here?
I think, for example, genetic counseling it's a very interesting point. For example, we know that a lot of patients they want to have babies, but they are afraid of the passing the gene on.
'Cause I feel like there's an elephant in the room when it comes to doctors and porphyria and rare disease in general. And I talk to a lot of patients who have experience with doctors and say they're not willing to learn this because there's not a whole lot of patients who have it, or whatever the case may be. What made you want to jump into porphyria specifically? Welcome to Rarely Discussed, an American Porphyria Foundation podcast with your hosts Andrew McManaman
and Nicole Castellano.
We have porphyria, a rare disease. Rare diseases differ greatly but share many similarities in how they affect our lives.
Being rare can feel lonely and isolating, but we're stronger together. Join us in meaningful interviews with porphyria and rare disease experts and the patients and families impacted as we connect, learn, and heal together.
We'll talk diagnosis, treatment, pain, mental health, managing daily life, and everything rare. Today on Rarely Discussed, we're joined by a leading voice in the world of rare diseases, Dr. Charles Marques Lourenco. Dr. Lourenco is a clinical biochemical geneticist whose work has made a significant impact on our understanding and treatment of porphyria. With a deep focus on both the hepatic and cutaneous forms of this complex condition, he's contributed to cutting edge research, presented internationally, and played a key role in improving diagnostic testing and clinical care for patients around the world. Whether it's uncovering the mechanisms behind porphyria-induced paralysis or helping physicians navigate rare dual diagnosis, Dr. Lourenco brings clarity and compassion to some of the medicine's most mysterious cases. We're honored to have him here with us today to shed light on what porphyria is, how it's evolving in the medical field, and what hope looks like for those living with it. And today, I have the honor of sitting down with him. Welcome to the Rarely Discussed podcast. I appreciate it.
Thank you very much, Andrew.
Of course, of course. And I just wanted to kind of jump in because I feel like there's an elephant in the room when it comes to doctors and porphyria and rare disease in general. And I talk to a lot of patients who have experience with doctors and say they're not willing to learn this because there's not a whole lot of patients who have it, or whatever the case may be. What made you want to jump into porphyria specifically?
Well, I'm a clinical geneticist, so usually we are facing very difficult cases to unravel. So most of the times when people refer patients to clinical genetics are patients that don't have a diagnosis. So usually the clinical geneticists, they are passionate about searching for a diagnosis for the patient. And sometimes we don't have the resources to do this. And my first porphyria patient was a patient as a young man that was in a psychiatric ward, and some I remember that I was in my first year of medical residency when they called me to make an evaluation of the patient, and then I thought about porphyria because I did not know a lot about porphyria about that time. I remember that this patient, every time they changed the psychiatric medication, the patient got worse. And then reviewing his files, because most of the time we need to review the files of the patients. I believe that this is a problem of the physicians, because sometimes we read only the appointment. The request for the appointment, but we don't read all the files because sometimes they're big files.
Yeah, right.
But sometimes there are clues. It's like a Sherlock Holmes of clinical medicine. And then I read in the nurse appointment, not in the physicians, that he had a lot of abdominal pain. But he had a very rich psychiatric outbreak that he saw like a dog barking all the time, and they had like visual and auditory hallucinations. And this is a
Mm.
very important point, because usually the patient that had, for example, schizophrenia, he only have auditory hallucinations, and he had a mix of visual and auditory. When you have like visual hallucinations, it usually means that you have to look for organic cause, like something toxic, something, a tumor, for example. And this was the point. I read the worse of the pain when he changed the medication, the worse of the psychiatric symptoms, and all the medications, it seems to make him worse. And then I thought, okay, it could be porphyria, although he did not have the red urine that we are looking for. And then I start to read about, but in that time in Brazil was so difficult to have the biochemical diagnosis and even the genetic diagnosis. Then I decided to look for in the internet, and I found American Porphyria Foundation, and I sent an email to Desiree. Please help me. I think I have a patient with porphyria that is locked in a psychiatric ward, and we need to know if there's some tools that we can use to diagnose the patient and maybe treating the patient. And then
Mm.
I received the response from Desiree saying, "Oh, you seem interested in porphyria. Yes. Would you like to study more?" So I was a little bit like called for the work, and I said, I said to him, please, lady, I have only one patient, and I'm not sure if he has porphyria. And said, no, no, you are the perfect candidate to learn more.
That's so funny.
Because I think this is the point. Many physicians, and I know that the patients, they complain, and it's true, they are afraid of telling that they don't know. And in genetics, I learned that we need to be humble. We need to say, okay, I don't know, but I promise you I will study about it. I try to study. And at least this week, I said this 7 times that I didn't know, but I will try to study. And I showed the patient, because you don't need, it's impossible to know everything. But sometimes the physicians, they like to have this an impenetrable shield that say that I know I have the knowledge. But sometimes to appreciate that you don't have the knowledge, but you look for the knowledge, is a very good answer. You don't look weak in front of your patients. You are learning with them. And so I decided to study. And I must say, uh, even it was like, this was in 2007. So it almost 20 years I'm in this field. And I must say that every time I learn something else about this. And it's funny, because it's all the time. For example, this week a patient, the spouse of the patient, she asked me, if drugs, like not medical drugs, can induce a porphyria attack. And then I realized, oh, I never studied about it. If, for example, some of cocaine or other drugs can induce an attack, I never read about it. And then I tried to study, and I found a paper in 1972
Hmm.
calling that. And there's an attack triggered by cocaine use that was
Interesting.
published, but it was lost in the literature. So, okay, it was nice. She asked me that, because I told her, oh, I don't know. I need to study. And I found this paper, and I showed her in the last appointment. Okay, you were right. Maybe your husband attacks can be triggered by this. And I think that this is the fascinating part for me as a clinical geneticist, that I every time I learn something about porphyrias, it's like there's a never-ending cycle of knowledges, and new things are adding. For example, now that we are doing the molecular genetics more and more, we are find out there are a lot of patients that have the mutation, and they don't have a lot of symptoms, or sometimes they have a mild presentation, so mild that they think that the abdominal pain that they have is like for food poison, for example. And
Right.
indeed they have porphyria, but it's a very, this week, for example, we found a mother and two daughters, and one of the daughters said that they say to her that it was only the cycles, that she was not used for the she was not used to the pain from the menses. And
Hmm.
but was not. It was the porphyria, because it was always the time that she had the pain is before the menses. So it's usually a premenstrual pain, and she was right. It was not part of, and she could tell the difference, that she felt this strange pain, and then she had the cycle.
So it definitely shows up in many different ways. But I wanted to, just because we're talking about patients and conversations you've had, I was curious about just in your years of dealing with people with porphyria and just coming against with people who have it. What is your most unusual or crazy story diagnosis you've come across?
Well, there was one case. This one is very interesting because the patient had it's not so unusual, but she had what we call the SIADH, is like is a inappropriate secretion of antidiuretic hormone. Is a condition that the patient that have a problem with the electrolytes, and then she could not urine, for example. She could not she could not go to the bathroom. She was like with the bladder full of urine, but she cannot urinate. And uh, and she started to have some psychotic behavior. And it was very hard because most of the times the tests for porphyria, they are made in urine,
Right.
and the patient could not urinate. And the problem is that it can be a very rare presentation of porphyria starting this way. And the problem is that I remember that we needed to put her in a nursery, but I was all the time asking for the mother, please, she needs to urinate. And then she was very, very she could not rest. And this is another point of porphyria. When they have these attacks, they feel like restless, they have
Mhm.
insomnia, and they start to have like a meltdown. It's like a confusion state, like they are not understanding well. They sometimes can be aggressive, but not because they mean to be aggressive. It's like they are not understanding the situation. You're very, and so imagine her position, like a guy asking for urine. She cannot urinate. The bladder is full, and she cannot urinate. And she's in a different place with a lot of people, strange people. And I keep asking all day long, because to have a little bit of urine to do the rapid test, I need to stay all day long asking for urine. And she said,
Mhm.
I imagine her thinking that, yeah, I must be crazy because these people is asking me for urine and a lot, and that they lock me up here. And I know that she was very distressed. And finally, at the end of the day, I could have some, and we did the test and it was positive. So we could start the treating her, but we are afraid of this. We need to do like a vesical catheter to drain the
Yeah.
urine. And this is a very, and the mother was very, she was like 19 years old, and the mother was suffering with her. And we tried to calm the mother and said, please, we need this because it's the way that you can say for sure that he has, because it was her first attack. And this was a very difficult situation because uh, still now we need the urine in these patients for the diagnosis. All the biochemical tests, we can do some in the blood, but most places is not available. So imagine for disease that you need to diagnose it in urine, you cannot do this because the patient has an effect of the disease that prevents her of urinating. So this was like for me a challenging situation. And
Yeah.
at the end of the day, she got better. We started to do a glucose loading for her. And the problem sometimes is to have the specific treatment with amine, that sometimes can take time to have it. But she's doing fine. It was very, very interesting because after that, she had just one more attack, and now she's doing very fine. She
Mm.
had kids, and this is for me is the true mystery. Why some patients have repeated attacks and other patients just have one or two in the whole life? And we know that both patients, they are avoiding all the triggering factors, all the porphyric medications, and still one patient lives on attack by attack, and the other one only had one. Okay, it was a very uh, devastating attack, but now no more. So this is something that I'm looking for. And for example, we find out that patients that have repeated attacks, usually they have increase in homocysteine. Homocysteine is like a metabolite involved in the vitamin B6 and B12 pathway. And we realize, maybe it was the consequence of several attacks, but we realized at the time, like 15 years ago, that it could be a clue. And now the people from Spain, and they find out the reason. It was very, this is for me, it was very interesting because we find this biochemical abnormality, but we could not do anything about it. It was something strange. We presented in a congress, and people was like, nobody talked asking
Huh.
anything, and I said, okay, we might be wrong because nobody never saw that. But the people from Spain, Dr. Jordi, he noted this, and then years he sent me an email saying, okay, you presented an abstract in Stockholm in 2009, and I think that we have a clue about it. And he asked me the
Hmm.
permission to put in a presentation this abstract. And they said, okay, now I was curious, what's the connection? And they find out that, well, the heme is important to make the CIP, but also is part of the vitamin B12. And
Hmm.
the vitamin B12 to be remethylated, it needs to go with a cycle with the homocysteine. And when you have an interference in this cycle, you have increase of homocysteine. So he find out this, and he realized that patients that have several attacks, in fact, they have increase of homocysteine because they have a profound perturbation of this cycle. So usually are more severe patients. Okay, it does not explain everything, but
Right.
at least it's something that now we know. And for example, we can treat these patients given vitamin B6 for these patients.
Hmm.
But still, I think that is not the only story because there are other situations. For example, some patients, they have several attacks, but they never develop paralysis of the limbs. And other patients just have one attack and he has a loss of all the movements. And
Hmm.
sometimes, if you compare the biomarkers, the delta mean levulinic acid, the patient that have several attacks and never develop the limb paralysis, he has higher levels sometimes than the patient that have only one crisis and develop the paralysis. So this is something that I'm trying to understand, why some patients develop the paralysis, why some patients have this very severe denervation, acute axonal loss, and other patients don't. Okay, usually the patients that develop the axonal loss and have the paralysis, they have high levels of AOA and PBG. But I
Hmm.
find out patients that have more, even more increased levels, and they don't develop this. So it's not only the toxicity of these metabolites; it's these patients should have a susceptible factor for this, and I would like to find this factor.
I would be interesting to know more about that because for me, I mean, I have AIP and I had one attack a year for 4 or 5 years, and then they just all of a sudden stopped, and I'm on a three
Oh.
year. I'm 3 years without an attack, and I have no idea why it stopped.
This is the point. Why this happens? There's something that I don't know. Maybe you measured your homocysteine levels.
I mean, I never even dug more into it. I think I was more just so grateful that it didn't happen again that I was like, okay, it's good. But it's something to look more into because obviously, to your points, I don't understand it because there wasn't a drastic lifestyle change. There was, I mean, I'm living life normally like I always have, and it just stopped. So it'd be interesting to look into that more.
Yes, because if we could find out why this happens, why this, and there are some patients that, for example, they always have AOA and PBG high. always, and they don't develop crisis. But we know that, for example, this kind of patient, they can start one attack with a small trigger effect. So we always keep our eyes on them. I always recommend to do at least once a year, even though you don't have attacks anymore. You should always measure AOA and PBG at least once a year, just to see how they compare. Because some people we call like they are high excretors. They always
Hmm.
have AOA and PBG high, so they are prone to have more attacks. It doesn't mean that they will have attacks, but they are prone. And one factor that we are trying to understand is the hepatic cancer. So maybe the patients that are high excretors, they can have increase in the rate of hepatic cancer, because you know that AOA, for example, is a little bit oncogenic. They are produced in the liver. So if you have a constant increase of these metabolites, it can induce mutagenesis. But in decades, like it was 50, 60 years of age of life.
Huh. I mean, it's valuable research to be doing because obviously I'm one of those people sitting back wondering why is this happening. So it's interesting.
When you have the attacks, you have a lot of exercise. You are doing a lot of exercise now,
Uh-huh. Yeah.
and now you doing the same amount of exercise.
I was one of my last attacks, I was playing college hockey, so I was exercising a little bit more, overexerting, and I'm not doing as much exercise as I did in that sense, uh, but I'm still exercising regularly.
No, okay. I think it's very important to exercise, but for
Mm.
example, if you're an athlete or you're demanding high levels of EM for the activity, maybe this could be one of the factors that can trigger a little bit. But I don't think that this could be the only factor, because there are people that are athletes and they only start to have attacks years after exercising.
Interesting.
But maybe it could be something because you are pushing too hard at that time.
And it's not something that would just snap and happen. It actually would take time for that to kick in, for it to kind of come from that
Yes.
exercise that happened years before.
Well, usually it'd be the period that are more like pushing too hard, like weeks or months in training so hard that you can push the system. But maybe something more like a cold. You had a cold at that time. You ate less. You are more on protein and less on carbohydrates. And so I always believe there's a combination of small factors
Mm-hmm.
that could triggers, and then it's like you're starting to have one after another, and then they can stop when there's all these little triggers, they start to disappear. But okay, this is only personal observation. There are
Yeah.
some patients that still, for me, I like, they are like a mystery. And but we know, for example, that some patients that they starts to have attacks again with 60 years or 70 years of age. Usually it can mean that they have cancer.
Hmm.
We have a patient with leukemia that starts to have, and he had AIP, but he starts to have the first attack with 65 years of age. That's very unusual to have your first attack. But in some way, they like the cancer. Maybe because they're consuming too much of energy and heme, and then we have the trigger, the potential. And there's another problem: chemotherapy. You know that we had a patient with AAP, and she did not have an attack for 20 years, and then she started chemo for breast cancer, and she starts to have attacks again. Most of the
Hmm.
chemo is very important that the patients know that most of the chemotherapies, they are porphyrinogenic. It's very important to raise and to talk to the oncologist to explain why sometimes you need to change the chemotherapy to one that is not porphyrinogenic.
And there's actually a testimonial to that because one of the recent guests on the podcast, Michael Boone, he has cancer too and porphyria, and he found with the certain chemotherapy he was getting was triggering attacks, and that's something that he
Oh,
figured out.
interesting.
Yeah, so would you say that porphyria is something you have found pretty tied to cancer, getting cancer? Is that something that you would say happens or no?
No, of you know that the AAP gene now is part of the oncogenic genetic panels. They are put in the AAP gene because it's now they are considering the mutations in the AAP or the HMBS, the gene, like
Mhm.
a risk factor for hepatic cancer. But they could not find this for other cancers. So I think that is more like the if you have the mutation, a pathogenic mutation, and you have a cancer, maybe the cancer can trigger this. There's a very interesting case of a patient that has the ALD, that is the ALAT, that's the recessive acute porphyria, that he started to have the attacks when he developed a dysplastic anemia. It's a kind of hematologic oncologic disorder, and
Yeah.
uh, and he had only the mutation in blood. The mutation was not it's like he was a mosaic for the mutation,
Huh.
and even though he developed the symptoms, this is a very interesting case that shows that the mutation was not in his uh, um, for example, we call germinative mutation when the mutation is present in all your cells, and in his case the mutation appeared only in a part of the cells because of the cancer, but he still developed symptoms.
Huh.
But this is very rare. This is very,
Yeah.
this is not
It
very
sounds
common. But you can be a mosaic for the mutation as well. So, but it's a very specific situation that proves that you can acquire some mutations as well.
right. So I was curious when you're talking about these specific rare cases and some of the hardships of trying to figure out why attacks happen versus why they don't. What other hardships would you say you're facing with other porphyria patients, if any?
With the cutaneous, for example, or in acute in general.
Just I would say in general for the porphyrias.
One of our problems, for example, is with the patients with the congenital porphyria. I know that it's very rare, but it's the porphyria that we can cure if you do a bone marrow transplant in these patients. It's one of the curable porphyrias. But the problem is that most of the times when the children are diagnosed, they are too, I don't say too old, but the problem is that these porphyrias sometimes they have anemia and they receive blood transfusions. Every time you receive a blood transfusion, you make the bone marrow transplant harder to work because you are combining different antigens. And this is and I'm always worried because the pediatrician should recognize these cases because our children that the urine gets red is not it's very unusual. I think that one of the problems is that nowadays you don't see the diapers anymore. You take the diapers and you 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 eliminate them. But well, there are some people now that are more sustainable. They are using a recycling the diapers like the tissue. So in this
Mhm.
case, you can see the that you have a very red stain when you expose to the sun, but most
Yeah.
of the times these patients are not diagnosed. I don't know why, because somebody at any point should see this. And they have like the problem is that they have splenomegaly, that's increase of spleen, and they have anemia, and usually they go to the hematologist. But the hematologists look for hemolytic anemias, and they do not put the cutaneous porphyria in the differential diagnosis because sometimes you don't have the blisters in the skin,
Right.
and you only have the hematological findings and the urine that sometimes people cannot see because they are in diapers. And this is a very sad for me because we had like four patients, all of them arrived too late for the bone marrow transplantation, and they need to live without sun exposition. I know that now they are trying two medications. They're doing like They are trying to do a chaperone. That's a molecule that can increase the residual enzyme in the patient, and they are trying to do gene therapy. I think that gene therapy would be the solution for this congenital one because it's very sad. Usually, if they are getting expositions, you can lose the fingers. You have scarring in all the face, and it's very. And you know that if you could diagnose this early, you could save, could avoid all this. And we need to be closer to the pediatricians to explain that you have to put porphyrias in the differential diagnosis of splenomegaly. You know that there are some of this porphyria you can have a very severe fetal presentation that the baby develop hydropis fetalis. That's so severe that the baby has congenital malformation and they die after birth. So you can, as it's a very severe presentation of this cutaneous porphyria, and many times they call like no immunological fetalis, hydropis fetalis, and porphyrias can be a cause of this, the cutaneous, the congenital porphyria, what they call Gunther disease. And this is a point that we're failing, very, very failing. We need to increase the awareness because we talk a lot for the adult clinicians about acute porphyrias, but the cutaneous one that are very early onset, we don't talk to pediatricians because usually the acute ones they don't have pediatric presentations, so we don't have this contact with the pediatricians to talk about porphyrias
Mm.
talk more about porphyrias. And we had a case of, that these patients, if they have jaundice, and usually when a baby have jaundice they put like lights in this baby. So this baby, if you put lights, the skin burns, like the skin have a lot of blisters, and they can turn like gray, the area. So you need to take out the lights, and this can be a severe presentation as well. We had 2 years ago a baby that was like that, and you realize that they only thought about porphyria when this baby did a genome sequencing. After genome sequencing, they thought about porphyria because
Hmm.
he had a variant of unknown significance in the gene. It was a homozygous one, and the parents are consanguineous. And this was the point that they called me, and they said, "No, it makes sense. It's in fact there are reports about this presentation." And but it was too late for the bone marrow transplant because the baby developed a lot of liver problems. They say that's very rare, but I'm starting to think that maybe it's not so rare. But most of these young children they die without a diagnosis.
So, what would you say you would do in terms of creating awareness for those doctors to think about porphyria at an early age like that?
I think that to put, for example, not always you can see the signs of porphyria like this, like visible signs, because people are always looking for skin or pain, and sometimes you can only have splenomegaly, or if you have a child with hemolytic anemia and splenomegaly, don't forget about porphyria. You can have porphyria in children as well. Or if the baby uh, reacted to the lights, think about porphyria.
Hmm.
At least have the skin, because we had a case this year. It was a baby from a native tribe. It was the first porphyria case in the tribe, and the baby has a severe jaundice. And then when they put the lights, the baby turned gray.
Hmm.
Like all the parts that show the light, they change the color and they start to have blisters. Because you have another disease that can have blisters in the newborn, is epidermolysis bullosa. Epidermolysis bullosa, you have a lot of blisters, but it's in the areas that you have some kind of contact. You have any contact, you have the blisters. So they are all around the body. In this case, no, the blisters are only when you have the light.
Okay.
So you can differentiate and think, okay, it's not epidermolysis, because the treatments are very different. In epidermolysis bullosa, you need to be very careful in handling the baby to avoid any pressure. And in the case of the this congenital porphyria, you need to avoid the light and try to do a bone marrow transplant.
And I mean, at that age, a bone marrow transplant is, I mean, the risk of something like that is pretty high too, right?
Yes, but at the same time, they are the best candidates because they do not have exposition to a lot of antigens. So
Right.
the chance to have a good outcome is very high as well. Because every time that they receive the blood transfusion along the life, it means that it will be you have a high probability of having a rejection of the transplant. So sometimes they avoid doing because they know that the outcome will be poor in this
Hmm.
patient. But okay, now is the possibility of gene therapy. This changed the games. So we are very hopeful that this could happen, and I know that they are trying to develop this oral medication as well. The people from Spain, they developed a chaperone that could, but the chaperone only works if you have a residual activity. If you have a very severe mutation that you don't have any enzyme left or very little enzyme, the chaperone will not work.
Well, what other treatments are just? I know obviously you're over in Brazil, but what does treatment look like for the porphyrias and things like that? I mean, what are you doing different if you can share, if you can touch on things like that?
Well, in Brazil, our main problem is access to therapies. Right now, we have been trying for like now 10 years, 12 years to put like at least hemine in the national health agency, like a drug necessary to treat the attacks. And every time we tried, we failed because they say that the publications are not very good. Okay, because most of the publications are from the 80s, and
Hmm.
they usually when they evaluate the technology of a medication, they look for perfect studies that you do what they call double bind. For example, you were using the drug that the group is not using, but you don't know, and the patient they don't know, they don't the patients don't know as well. So it's double bind. The problem is that how you do this is porphyria, attack porphyria, because you know that if you don't treat the attacks, it can progress and the patient can die. So you cannot do a double blind.
Hmm.
It's criminal. We showed them then, and for example, even the study for Givosiran, in the Givosiran study, if it was a double blind, but if you have an attack, you could use heming in both blind and the placebo and the not placebo group, because they realized that the attack could be very severe. And how you can do this if the imine is the drug that you use in these situations? So you cannot have a double blind. It's not ethical to do a double blind. And then we are trying to once more look for literature and put together this. One of our problems is that in the past they registered the panematin. If you read the inside of the medication, they say that it's for women that have repeated attacks.
Hmm.
It's true. It's written like that because okay, in the past it was a lot of women had like several attacks related to the menstrual cycles, but we know that it's not the only presentation. But it's still written in the American Panematin, and when they translated it into Portuguese and they submitted like that. So this is
Hmm.
always a problem because they said, okay, so men should not use it because you
Right.
wrote that's for women with repeated sex. So this is very problematic. We're trying to change. It's funny because if you look for the hemarginate, they don't wrote that. They didn't read that. They write this, but I don't know why they put this in the Panama thing. This is a
It,
very and they translated directly from English and submitted. It was approved like that, and every time we try to submit again, they say, "Okay, but it's only for women."
do you know? I mean, do you have any idea why it would be written that way and not changed to where it could be given to more of the public?
Because I think that if you review the literature from the 80s, It's true. Many women had repeated attacks, and we know now that they are related to the erect, the problem is that why women have more attacks than men, because of the oscillation of the hormones. So when you have this oscillation, and you know that, for example, estrogens can be porphyrinogenic, the main question is that when you have this oscillation each month, you can trigger an attack. And it's very interesting because some of our patients, when they got pregnant, they told me, I never felt so well in my life. They said that they finally they don't have pain. And one of my patients, she was a physical education teacher. She said, I want to be pregnant all my life. And it was fascinating because her levels of AOA and PBG, they dropped to zero. Zero, zero, zero. She never had zero. They always have been high. And they normalized it. And she had like four children. I think she was feeling so well that she decided to have four in a row.
Right.
But now she sent me a message like last year, and she had her first attack after many years. She her last pregnancy was 2 years ago, and now she started having the attacks again. And it proves that the if you have like a stable hormone for months, you can have a protective effect. And in that time, they saw that these women that have several attacks, they have this related to this menstrual cycles. So they registered the aiming for this purpose because they thought that people usually only had one attack in life. And only those women were prone to have more attacks. Now we know that is not true. We can have men with have several attacks as well. And
Right.
you have some female patients that they have attacks that are not related to the menstrual cycles. You know that, for example, in the past we had problems with the oral contraceptives. We had some patients that, and I remember some of the mother that had the attack tell me, no, 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 my daughter will not use contraceptives because I had my first attack when I used the and explain, and I need to explain that there's a difference between the old oral contraceptives with the new ones. The new ones, they have a less amount of hormones, because if you see, well, the contraceptives, if you're taking for the first time, they have high levels of hormones, and they potentially cause a crisis. But now they are okay. When a patient that I know that have a mutation is daughter of a woman that had attacks with contraceptive, we always discuss how to introduce the contraceptive, the oral contraceptive, and sometimes can be very helpful for the patient that have repeated attacks. You can at least attenuate, modulate the frequency of the attacks. But there are some women that we try everything, and the only way that we could do a difference is when we try to stop the menstruation, inducing a menopause. But the problem is that when you induce the this, you can create other problems like osteoporosis. You can increase the risk of certain types of cancer and endometrius. So you cannot do this forever. These patients, for example, we are noticing that they can have benefit using givosiran. So now we change our approaches. We're trying to use givosiran as in these patients to see if we can stop this in avoiding to induce the menopause, at least in some cases. But in Brazil, it's not hard to get this. If heming is hard, givosiran is harder.
Yeah.
So what we still do, we try to for 1 year stop the menstruation, and we measure the AOA and PBG levels, and it's fascinating. They start to decrease, and when they are like zero, and then we use oral contraceptives and stop the GnRH analogs. Okay, in this situation, I need the gynecologist at my side.
Yeah.
Yes, and for me, it's sometimes it's very interesting because I learn a lot of this
Yeah.
hormone modulation, but sometimes I think about this the that I need to convince my colleague that we're not crazy. That
Y-
makes sense because he looks to me and said, "Are you out of your mind? You are trying to induce a menopause in a young woman that's healthy?" And I say, "No, she's not healthy. She has several attacks. Her life is a nightmare right now, and we are trying to make it better, change it."
So I wanted to ask you in terms of just where treatment and research is right now with porphyria. What hope do you have with getting closer to better treatment as of right now?
Well, I think that we had a breakthrough with the RNA silencing because it changed the game for the patient that had several attacks. But still, I think that we need something more permanent. And I know that people are doing gene therapy for at least for AIP. They're trying to deliver the virus in the liver. Okay, people are not so they were very afraid of the because you know that gene therapy sometimes you can have a immunological response. Some patients they can have develop immunological reaction to the virus antigens, and sometimes the liver is the main focus of this reaction. So they think, okay, we are treating a disease that the enzyme is in the liver using a virus that can trigger immunological effect in the liver. Are you sure that is a good idea? People
Right.
say, but we did this for other metabolic disorders like OTC deficiency that's also in liver, and they are doing gene therapy. The thing is you need to have a perfect virus, at least a virus that is viable and not cannot induce reactions, and this could be like the cure if you have this transduction of the virus and the correction of the mutation in the liver, and the liver starts to produce the enzyme, the correct enzyme this time, it could potentially cure the disease. We don't know if it would be necessary to have new inductions, new virus transfections, but maybe just one wouldn't be enough because the liver can repopulate itself, its own cells, so it can repopulate with the correction. So this could be, oh, it could change everything if it
Yeah.
works. But I'm not sure that I need to be more hopeful for the gene therapy, but I'm not sure if they could change because in the mice it worked very fine. They needed to do several times, but now the mice was cured, and I believe they tried in the cat, and the cat also have a good response, and now they're going to humans. But for example,
Hmm.
in this setting, you need to do at least it will be like four different ones because the virus only corrects one gene. So if you works for AIP, then you need to do for C variegate, and then the to the hereditary copper porphyria, and maybe the one that's more difficult to treat, that's ALD, the recessive one.
Hmm.
But this is the point. Each gene therapy will be very, very costful. So if you need to do four gene therapies, I'm not sure that it will be economically viable. I don't know if there's any lab that would be interested in doing this. Yeah, yeah, you reach a point, Andrew, that you have the technology, but you don't have the economics because they are very rare diseases. You know, for example, that all the gene therapies that are approved, they were very high cost. They are very, very well. For example, for Zolgensma, that's a spinal muscle atrophy. It was in the beginning the most costful therapy approved, like more than $2 million. But you can, in theory, and it's proven it's right, you cure the disease forever. If you put the cost that you have each month for the whole life, it will be more expensive than you do like one just single injection.
Right.
And all the kids treated, they do not develop symptoms at until this moment. We did not have any case that you need to do again the gene therapy. So maybe we are talking about a potential one-time therapy that will be very very expensive, but it's just one time.
And would that be when you're young, just before anything happens, or would it be available at any point in your life, do you think?
Well, those ones only feel young, because the problem with those ones is the amount of the virus that you need. For example, for Zolgensma, they are only approved until 1 year of age, because the amount of virus that you need to do the intravenous injection, it's very very high. The people estimated that the amount of the virus is equal to the number of the stars. Is a is a poetical way to say that's a lot of virus. This is why they are.
Hmm.
So if you do for an adult, it'd be unfeasible. But the question for the porphyria is that you don't need to do intravenous, like to all the nerves. You just need to go to the liver. So the
Right.
amount of virus is not so high. But the question is that
Right.
it will be enough for that the replication of the liver produce the enzyme for the whole life. This is the point, because a mice have a liver very tiny.
Right.
You have a human is a very, yeah. We know that the liver is the question, because you know that there's a time that the only answer that we could have for patients with repeated attacks was liver transplant. We did in Brazil 4 liver transplants. Unfortunately, 2 died, but of liver of the complication of the transplant. But one of them, it was very interesting because it was a male. It was a man. He had variegate porphyria, and he had so many attacks in the last 6 years, so many, that every time we tried him in, the AOA and PBG, they decreased, and 1 week later they were high again. And then
Mm.
when we did the transplant, normalized it. And I remember he told to me, for the first time, I'm free of pain. And he died 1 week later. But not
Mm.
but not of the porphyria. He had a thrombosis of the and now we know that some of these patients with porphyria that had the transplant, they had a high increase number, well, a percentage of complications of thrombosis higher than other patients that have liver transplantation. But I remember that his wife told me that she was happy because he was not feeling pain anymore,
Hmm.
and the AOA and PBG normalized. And we had another Brazilian that was funny because she was the first transplanted patient in the world for porphyria, and she was transplanted in Stockholm because she
Hmm.
married a Sweden guy, a Swedish guy. Yeah, a lot of Brazilians, they marry gringos, as we say, and she married a Swedish guy, and well, he didn't know that she had porphyria. But
Uh,
it was, I told her, well, okay, you married the perfect guy, because in Sweden they know all about porphyria, and the AAP is called the Swedish porphyria, because they have is the country is the they know all the families with AAP in Sweden. It's very interesting. They do like uh, uh, all the general physicians, they know porphyria because of this. They know all the
hmm.
families. So when she went there and she started to have attacks, they rapidly diagnosed her. They and it was funny to have porphyria in Swedish in Sweden, but they realized that she had a very severe form, because, well, it was not a mutation common in Sweden, and she was transplanted. This patient, it was
Hmm.
the first one they decided to go for the transplant, and she stopped having pain, stopped having hospitalizations, and she had even paralysis, and she slowly recovered from the axonal loss in the nerves.
Hmm.
But okay, now she's a liver transplant patient. Like she needs to use drugs to immunosuppression for her whole life.
Right.
But
Right.
now we realize that the liver was the questions. If you could change the enzyme production in the liver, we could have this effect. It works for the hepatic porphyrias, but not for the hematological porphyrias. For example, EPP. EPP is on porphyria that it's the problem is the is not the liver. Yeah, although they develop liver complications, you need to the only way to cure EPP is doing a bone marrow transplant as well.
Right.
So if you are trying to do gene therapy for the other porphyrias, you need to go to the bone marrow, not for the liver. But they are now, for example, for APP now, they are developing at least two new drugs that could be very helpful for APP. So I think that we are changing the game for the cutaneous as well.
Yeah, and I think it's been a long time coming too. But I also wanted to ask you something, just because for the people that are watching or listening that are just I don't know if I have porphyria, if I do, or how do I deal with this? What do I do with this, that, the other thing? I was curious what advice you'd have for somebody that's watching this that has porphyria or doesn't know they have it. So just a broad question from you, just to get your advice on how people should just deal.
Well, I think it would be nice if you can talk to a physician to explain. I know that sometimes physicians are very hard to believe in, and usually if the patient comes with a suspicion of the diagnosis, he always tells who's the doctor here. But
Right.
you can persuade him and showing that why not we can look for this disease, maybe and sometimes because the problem is the order the correct testing. And if the physician opens the medical books, they always put like porphyrins, and porphyrins are not the best, but is not a good test for acute porphyrias. So if you have abdominal pain, you have uh, tingling sensation when you have this pain, you have hypertension, you develop insomnia when this pain comes, you should look for acute porphyria, and you need to measure AOA and PBG. It's not very good to do the genetic testing. Why? Because we know that the mutation, the frequency of the having a pathogenic mutation in one of the four genes for acute porphyrias is not so uncommon in the population. You know, Andrew, that for example, for AIP, the frequency of a pathogenic mutation in the genome databases is like 1 and 2000, 1 and 800s. It's not so rare, but
Right.
you don't have so many patients. Why? Because most of the times you have the mutation, but the gene does not penetrate. It's a term that you use in genetics called penetrance. And you know, for example, for AIP, the penetrance is not very high. Uh, at least 70 to 80% of the patients don't have that have a mutation don't show symptoms. This is very
Hmm.
important because usually when the
Yeah.
physician asks about family history, they say, no, there is no case in my family. And it's probably true. There is no case with symptoms, but it's almost 100% sure that you inherited this mutation from your father or your mother. So there is very rare de novo mutations, porphyria. You always inherit it, but usually your father or mother don't have symptoms because most of the patients don't, the gene do not penetrate. Why? I ask you, why this happened?
Yeah.
For me, is another of the mysteries because we don't see this in other diseases. It's a very unusual having a pathogenic mutation that don't penetrate it in 70 to 80% of patients. Is it thinking about AAP? But the same they are seen for variegate and copper porphyria as well. Is very high the non-penetrance of the gene. So this is why you should not do the genetic testing first. You need to look for AOA and PBG. because if you're having symptoms, the biochemical biomarkers are defined in the diagnosis. If you do genetic testing and you found a pathogenic mutation, it does not mean that you have porphyria. You are carrier. You only have the disease if the biochemical markers are increased.
That's interesting. And because everybody always says just jump on the genetic test, and that'll be the tell all. So it's interesting
This
to.
is because, for example, we found a lot of the nowadays we found incidental findings. For example, we ordered tests. For example, we ordered a test for a patient with intellectual disability, and we found a mutation, and we found a pathogenic porphyria mutation as well. I know that the pathogenic mutation does not cause the intellectual disability, but when we go to the family, we found someone in the family that has repeated abdominal pain attacks. And when
Hmm.
you look for this patient, he has the mutation, and he has it. So we find that many patients can have the mutation. It can be helpful for looking at the family, but it does not explain your symptom. Even though you have very suggestive symptoms, you need to do the AOA and PBG. And but there's a situation very interesting when you are homozygous for the AAP mutation. If you have a mutation from one allele and the mutation the other allele, you can have intellectual disability. You can have autism. And
Hmm.
we have been finding some patients that are they are double compound heterozygous for mutations in the AAP, or homozygous mutations, and they have intellectual disability. And sometimes they can have local leukodystrophy in the brain. So this is a new presentation of the disease. And okay, in these cases, the molecular genetics is very important. If you have
Yeah.
two mutations, it's different from one mutation. Two
Hmm.
mutations are almost always penetrant. You see, there's a lot of to talk about porphyrias.
Yeah, I mean, there's so much. I mean, it just branches off into so many directions. It's just, and the new presentations are so interesting and fascinating to learn about, because it's endless. But I wanted to ask you before we wrapped up here, is there something that maybe we didn't talk about that maybe you wanted to mention while we're talking here?
Well, I think, for example, genetic counseling, it's a very interesting point. For example, we know that a lot of patients they want to have babies, but they are afraid of the passing the gene on. Uh, this is a very personal situation. We now it's possible to do, for example, pre genetic pre-implantation. You can screen for the mutations doing an extra of you can do in vitro fertilization, but before you implant you can look for the embryos if they have the mutation. I know that for some people this is a very complicated issue, because you know that having the mutation does not mean that you have the symptoms. But
Right.
I understand that if you are from a family that had a lot of people that suffering from the disease, you do not want your kid to have this. But
Right.
at the same time, I understand the families that they say no, I don't want to do this because I have the mutation, I have porphyria, but I'm also happy to be alive. So if I selected the embryo and I selected the one with the mutation, it's like I will be raising myself. I understand this point of, because if they did, if their fathers did it, their parents did this, he will not be or she will not be alive to have kids. So
Right.
I understand both sides. I understand the one that do not wish to have a kid with the mutation. I understand the ones that think that maybe you should give a chance. But I always ask the couples that they need to think about it, because it's different when you have a mutation and a disease that nobody knew about it. And if you have in this context, you in some way will be responsible for that
Hmm.
person. If in that point he develops symptoms, it can be very hard to explain why your parents have the chance to avoid this, and they choose not to do this. And I think this need to understand how you. I understand that most the patients that have severe presentations, they don't want the kids to have this, to suffer. Uh, but I understand the ones that, for example, choose uh, uh, to avoid selecting, like let the fate decide. And I think we don't talk a lot about this, and because sometimes people understand that having the mutation does not mean having the disease. But okay, you are you need to explain the patients all the possibilities, because
Hmm.
most of our patients are young people that want to have.
Right.
Sometimes they already have the kids, but and this is another point: testing or not the kids for the mutation. Usually, we say that we only should test when they are like 16 years old or 18 years old. But I am one of the persons that think that it's important to test the kids, because abdominal pain is a very difficult differential diagnosis in pediatrics. And sometimes it can be due to the mutation. I know that you could do a podcast about porphyria in children. It would be very interesting to have the discussion, because although it's rare, it's not so rare as you read in the books. We have a significant number of patients that develop in the with 9, 10 years of age, the first crisis.
Right. And that's what I think about too. Is I've chatted with people who have kids, and I've always asked, "Hey, did you test them? Did they get a diagnosis?" And they're just like, "I don't really want to for insurance purposes because it'll push my insurance up." But that's what they
Oh,
tell
okay.
me.
See, this is another point.
Yeah, a lot of people will tell me that, but even for me, in terms of the having children thing, it's something that's been on my mind too. Is what if I have a little girl who just so happens to have a monthly attack, and that's something that I often think about. How is that going to work? So it's to your point. It's a personal decision, of course. There's both sides to it, but it's a hard one, of course.
Yeah, yeah, I know. And you know that sometimes, I don't know if it's coincidence or not, but some of these girls that have the repeated attacks, when they hear it from the father usually is asymptomatic or only have one attack in their lives. Maybe because it's a male and have this hormone protection. But
Hmm.
if his child, that's a girl, hears it, the story could be different. The
Right.
clinical aspects on her could be more severe.
But I mean, of course, there's the aspect of I know what I have, and if they some symptoms arise with a young woman, then in my mind, of course, I can be first to say porphyria, but of course, it doesn't change the fact that they're going to be dealing with it repeatedly. So it's a thought process for sure.
Oh, but maybe we could avoid the triggers. I know for some people from Sweden, they are doing a very good job, and because they have all the families mapped. So, for example, when they have a girl showing abdominal pain, if she's from that family in particular, they do the mutation of the patient to know if she has the family mutation, and they start to treat her in the beginning. It could be a way to avoid, because most of the times is if you avoid some particular triggers, you can change the outcome only doing this. But sometimes don't. Sometimes it's more complex.
Yeah. I mean, outside of the hormonal aspect, what triggers would you say to try to avoid mainly?
Diets. You know that nowadays we're seeing a lot of patients, even male patients, showing the first attack doing this crazy diets that is not only the ketogenic diet, they call Atkins, that they eat a lot of protein and lipids, and they decrease the amount of carbohydrates. You know that
Hmm.
the carbohydrates, they have uh, uh, they can inhibit the AOS1 enzyme, and they can have a good impact in avoiding a crisis. But if you decrease the consumption of carbohydrates, you could increase the demand for synthesizing heme, and then you can start an attack doing this. And we first noticed that patients that do bariatric surgery, when they do the bariatric surgery, they don't eat anymore. Like the carbohydrate intake decreases, and we have patients that have the first attack and then repeated attacks after bariatric surgery, and the
Hmm.
other ones when they start the Atkins diet. And there is another one that has a funny name. It's like Jurassic diet, or it's a name
Like
like the
carnivore?
Cretaceous diet. Is is a diet that from the Jurassic time, that the people only eat meat and
Oh,
leaves.
yeah.
As I
Huh.
said, oh my god, this is crazy. This is crazy. I forgot
Yeah.
the name of Neanderthal diet. I don't know. It's something. It's a very strange diet. And I said,
Mm.
and how do you know that the people only eat that at that time? Maybe there was no meat because they could not kill the animals very well. Okay, but they
Yeah.
need like a beef and some leaves, and just
Yeah.
that. Not you don't have carbohydrates, so you decrease the carbohydrate. This could be a trigger. And now they are doing more and more this kind of diets. I'm wondering if most of the triggers can. We have one patient that started when she started the ketogenic diet, the Atkins diet.
Hmm.
So the diet, if you decrease a lot of carbohydrate intake, this could be a potential trigger effect. And of course, alcohol. Alcohol is fantastic. We have a family here that everybody drinks and everybody have pain, and we're trying to change habits of life, but it's very hard. And
Yeah.
it's funny because it's so cultural for them that they think that everybody that drinks have abdominal pain. I said, no, this is not normal. It's only in your family. If you
Right.
ask people if they drink, they have abdominal pain. They said no. They said it was like the part of the combo of drinking, having abdominal pain in the following day. I said, no, 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 no. It's not. It's not how people felt. You can have a lot of headache, but not abdominal pain like this. And we're trying to change. Well, at least they are now only drinking in holidays. But
Hmm.
it's funny because all of them have high levels of AOA and PBG, but they don't have repeated attacks. Only when they exceed in drinking, and they drink a
Hmm.
lot. But
Yeah.
it's funny because some patients can have drink like wine, crisis attack. And no, they drink a lot, and they only have attacks when they okay, they drink like bottles and bottles of beer, and they realize, okay, I think I mess up, I think I drank too
Yeah.
much, and usually they go to the emergency unit in the following day.
Hmm.
So I don't know if they are like they are so used to drink that they only start to have crisis if they exceed an amount. But I always tell them there's no safe amount of alcohol. You can induce a crisis even if you drink a glass of beer. At least
Yeah.
they decrease it, so I can be happy because
Yeah.
at least something they change. They said no, we're drinking only holidays.
So, what would you? I know you're obviously you're not a nutritionist, but I think it's pretty known in the porphyria community that carbohydrates are really important for us, and I think there's a misconception at how much of it you're actually supposed to consume because everybody says I need to indulge in all these carbs all the time, and they're gaining a ton of weight, and they're like, well, it's the porphyria, I have to eat a ton of carbs, and I just wanted to see if in your mind if you had like a gram per pound or anything like that in terms of how much carbs to eat a day for somebody.
I think there's a really a misconception. I have patients that are eating all the time. And I said, no, no, it's not the thing. The problem is like is carbohydrate deprivation, the problem, and not overloading carbohydrates. And the other point is that if you follow regular diet, you have the necessary amount of carbohydrates. The problem is if you decrease a lot of the carbohydrates during a diet. So you don't think, and the other problem that I'm looking in these patients that if you start to eat a lot of carbohydrates, you start to increase the levels of insulin. And if you and I'm looking at those patients, they are starting to have hyperinsulinism because of the amount of the carbohydrates that they are eating. They're eating too much. And if you start to have an hyperinsulinism, you start to have an hypoglycemia. And the hypoglycemia is a trigger effect. If you are hypoglycemic, you need him, and you can have an attack. So I'm very worried about this overloading of carbohydrates, because
Yeah.
people are becoming hyperinsulinemic, and this can provoke more hypoglycemias. And then it starts a very very strange cycle that you need to, if you have hypoglycemia, you need to eat more to increase the levels of glycemic levels, and then the insulin decreases again, and it's more potent because you're eating too much, and then you go
Mm.
down with the glycemia, and then you eat again, and this is very harmful for
Yeah.
the heme cycle, because the heme cycles need the levels of glucose, stable levels of glucose, and the hyperinsulinism, you will have consequences in these patients. We tried we presented an abstract in the congress showing that most of our patients with repeated attacks, they develop hypoglycemias due to the hyperinsulinism state they are, and they are
Huh.
always eating.
Yeah.
And for this
Interesting.
those patients, what we are trying to do, we're trying to use, for example, cornstarch, like cornstarch, because you can break down the cornstarch very slowly, and you can maintain the levels of glucose during the day or during the night to avoid the hypoglycemias on those patients. Well, at least the problem is that it's like cold cornstarch.
Mm.
It's not very tasteful, but I tell
Yeah.
them it's not to pleasure. It's medication.
Right.
Is that the way to maintain the levels of the, because the problem is that if you have small sugars, you break very fast, and then you can start to have a new hypoglycemia. And this is very important, Andrew, because I'm really concerned about this. And these patients, they are prone to have more attacks, even though they are eating all the time. They need to be very careful. They need to go to endocrinologist to measure insulin, glucagon, and other hormones, because if they're eating too much sugars, or even high amounts of carbohydrates, they are changing the glucose cycle.
I'm glad you said that, because there's a lot of people too, not just with carbs, but there's so many people in the porphyria community that I've talked to that say, I eat so much candy because it helps my porphyria, and people are just packing
No,
on the
no, no, no,
sugar.
no, no.
Yeah. So you're saying that it makes it worse.
Yes, there will be, how they say in the movies, there will be consequences.
You're
They
right.
cannot do this all the time. There will be consequences. I was afraid this in the beginning, but now I'm pretty sure that we have been facing consequences, because we are changing the glucose cycle. I can send you some papers that they wrote about. This is known for some time, but again, we need to reach more our patients, because
Hmm.
they have this misconception about sugars, candies, and no, we need to show them that the you have a lot of scientific work in the animals, and the biochemistry. And if you increase too much the carbohydrate intake, you are messing up the glucose levels, and this will be harmful, because if you stop eating, you can have crisis, because you make your pancreas addicted to decrease the levels of sugar. And it's funny, usually we don't measure the levels of insulin in the porphyria patients. We need to do this more.
No
You know
kidding.
that in the past they used it to treat patients. Well, at least in some scientific studies, they use like they give glucose overloading, but using insulin as well. They give
Hmm.
both, because there is a synergistic effect. And when you give both to the animal, you have a very fast decrease of AOA and PBG. So there is some
Mm.
synergistic effect. I know that Dr. John in Utah, he was doing a lot of this research. He started a small trial, but I think that he could not have the grants to continue this. And this,
Uh,
but it was a very important idea because we are knowing that people are perverting the insulin and the glucose cycles.
that's interesting. It's very good to know.
But okay, this is some papers. We need more doing regular studies in these patients. But I think as a warning, they should take it easy.
Hmm. That's that's good advice. That's good to put out there, I think.
Yes, because I'm afraid. Oh my! And I remember that there was a time I bought some candies for the patients, and I said, no, no, no candies anymore. No, we can do because some of our patients they become hypoglycemic. The levels of glucose they drop very fast, and I know this is because they became hyperinsulinemic. The insulin levels
Hmm.
are very high because they're inducing all the time the glycemia levels. They're eating too much sugars.
I thought that'd be a good place to wrap up with people to let people know that they shouldn't be eating so much sugar and so much carbs. But I definitely appreciate your time. Appreciate you. I know you're a busy guy. It took a little while to get you on here, but I
Yeah,
definitely
sorry,
appreciate it. No, that's okay.
but I
That's
think it was
okay.
the best
Busy.
place because I'm very relaxed at my home with my dogs.
Yeah, yeah. Right, right. But yeah, I appreciate it, and I can't wait for everybody to see this. So I appreciate it.
Thank you very much.
Thank you for taking the time out of your day to listen to our podcast. If you enjoyed this episode, please share it with friends, family, or anyone who could benefit. And please don't forget to subscribe and leave a review on your preferred platform. It helps us spread awareness, and we would be extremely grateful. You can also follow Rarely Discussed on Instagram, YouTube, as well as TikTok. If you're someone seeking diagnosis for porphyria, visit porphyriafoundation.org to receive a free doctor packet, forms for free DNA testing, and a list of doctors in your area. Stay tuned for more episodes of Rarely Discussed.